So as Niehaus goes through these interviews and discusses with the 25 informants, they're in fact not ignorant of biomedical knowledge. They actually know quite a bit. The emphasis in South Africa has been on prevention rather than treatment in public health campaigns. Um, and part of this is reinforced by the idea that, or the infrastructural uh, issues here with a lack of access to any sort of treatment in the area up until 2003. And then in 2003, the antiretroviral drugs were made available, but that was about 30 kilometers away from the village itself. So there's a notion that there's a lack of a cure out there, and then also a lack of treatment that exists out there, and then also concern over gossip as a whole. So from the Vice report on the condition of what's happening in Liberia right now in Africa, we see that, in fact, the burden of disease of Ebola is fairly dramatic in terms of the number of cases as well as the number of deaths in Liberia, Sierra Leone, and Guinea, with a few cases outside in Nigeria, the U.S., Mali, Senegal, and Spain. But if we look at much of the media reports in the United States in October of 2014, we can see a disproportionate emphasis on stories involving individuals in the United States, such as individuals that have been infected, the woman who got on the plane in Ohio and went to Texas, the nurses in Texas, the physician in New York, the healthcare worker returning in Maine who is defying quarantine, issues of constitutionality and whatnot, false alarms about Ebola, the concern about the spread of Ebola, and then a number of campaigns to educate the public about Ebola in all sorts of settings, including Bloomsburg University on bulletin boards, electric bulletin boards, and whatnot. So the WHO report, World Health Organization report as of October of 2014, and I should mention that I think this is about the 8th or ninth situation report that they put out on a weekly basis to document the response to Ebola and the current situation as a whole. The World Health Organization's Ebola Response Roadmap situation report goes through a number of key issues, and they have set plans and set target dates for achieving a dramatic reduction in the cases of Ebola. Among the plans, and this is directly from that text, among the plan's key objectives is to have the capacity to isolate at least 70% of the EBD cases, Ebola cases, and safely bury at least 70% of the patients who die from Ebola by the 1st of December 2014. That's the 60-day target. The ultimate goal is to have the capacity to isolate 100% of cases and safely bury 100% of the patients who die from Ebola by the 1st of January of 2015, the 90-day target. The WHO estimates that in order to accomplish this, there is a need for 528 trained burial teams in the 3 countries with widespread and intense transmission. And again, that's Liberia, Sierra Leone, and Guinea. Currently, however, there are only 140 trained teams that are on the ground, including 34 teams in Guinea, 50 teams in Liberia, and 56 in Sierra Leone. This is being done in partnership with the International Federation of the Red Cross, the key partner in the management of safe burials. The World Health Organization estimates that it requires $260 million in order to meet the objectives of its response to the Ebola outbreak. To date, the World Health Organization has received 49% of those funds, while 15% of the funds required have been pledged. This leaves a gap of approximately 30% of the funds that are needed. The WHO continues to appeal to member states to provide funding and other resources to assist in containing the Ebola outbreak. So anthropologists have been writing and researching in communities for very long periods of time. They know about things such as cultural norms in terms of burial practices, in terms of kinship, and in terms of importance of ritual and the grieving process. And they're very wary of programs which do not take into account cultural considerations in implementing medical interventions, and the potential ramifications of the lack of consultation with anthropologists and hence with the local community concerning the medical response overall. Because in some instances, the medical response can be hampered quite a bit by beliefs and practices of local individuals. At the same time, those same practices might actually contribute to and those individuals might have a role in diminishing the incidence, the spread of disease overall. In 2008, Barry and Bonnie Hewlett, a couple in anthropologists, wrote the book Ebola, Culture and Politics, The Anthropology of Emerging Disease. And this again is a 2006 book, and they discuss Ebola as a filovirus, and the filovirus family that has a thread-like morphology. Its philo is Latin for filament, noting that there are in fact 4 subtypes of Ebola: Zaire, Sudan, Reston, and Ivory Coast. The Zaire and Sudan subtypes are responsible for 90%, 95% of all cases. When they were doing their work, they noted a number of locations of the Ebola outbreak, including in Sudan, where you have in 1976, 1979, and 2005 outbreaks of Ebola, or the filovirus. And the number of cases in Sudan in 1976 was 284. In 1979 it was 34, and in 2005 it was 17, with 41% mortality rate. In Gabon in 1994, there were outbreaks in 94, 96, another one in 96, and then 2001 to 2002. This also occurred in the Congo from 2001 to 2002. In 2002, in 2003, there were 2 outbreaks, and in 2005. In Angola in 2005, in Uganda in 2000, in the Democratic Republic of Congo, or Zaire, in 1976, 1995, 1999, and in 2007. So we can see that the Ebola outbreaks have occurred with some frequency, particularly in Central Africa, which is where Hewlett and Hewlett concentrate their research. And they note a number of things which get in the way of healthcare interventions overall. And in the final chapters, they speculate on the role of anthropology for dealing with what at the time were contemporary threats, such as the threat of bird flu epidemic, as well as Ebola use as a bio-terrorist weapon. They conclude with their Appendix A, which discusses the role of the medical anthropologist in an outbreak alert and response. And the role of the medical anthropologist, according to Hewlett and Hewlett, they can be involved in the preparedness phase, the early acute phase, the duration of the acute phase, and the final phases overall. And I'm just going to go ahead and go through a couple of the suggestions that Hewlett and Hewlett offer for how anthropologists can contribute to the Ebola, to helping to contain Ebola and lead to better health outcomes for affected populations and regions. I should note that the brief NPR recording also talks, there's a 3.5-minute clip that talks about some of the work that anthropologists do. In terms of preparedness, they note that as soon as a case is confirmed, a medical anthropologist should be contacted. They would identify and contact the ethnographer, who would conduct a rapid literature review and write a summary essentially for the World Health Organization in order to distribute to all team members going into the field. They estimate that this would take 2 to 3 days. From there, in the early acute phase, they would assist with descriptive epidemiology of early cases, develop an understanding of naming systems, assist epidemiologists in developing culturally sensitive and appropriate case record form. They would begin a study of the explanatory models of disease by interviewing traditional healers, elders, survivors, healthcare workers, and others. They would identify local political, economic, social, and religious structures and organizations that might assist in control efforts, particularly those that are already on the ground and have established trust within the community. These are key stakeholders in the dissemination of information. They would help develop immediate control measures, such as hygienic measures, immediate health education, and participate in the development of preliminary hypotheses to explain the disease, including who is at risk and the modes of transmission. Once the medical anthropologist has been in the field for 2 weeks or so, they should have enough information for a preliminary report incorporating specific findings into various components of the outbreak response. That would train clinicians and laboratory workers on the behavioral aspects of the disease to enhance physician and patient relations and community trust, to collaborate with health educators to develop culturally sensitive and appropriate health education messages and strategies, to assist epidemiologists with kinship charts and other tools to follow transmission patterns, so this idea of contact tracing that was discussed in the Vice film, which has also been, of course, discussed in the United States as well, who individuals have come into contact with and potentially spread Ebola. During the duration of the acute phase, they should work closely with healthcare workers who provide services to the sick, exposed, and survivors to identify emerging problems and issues, identify and follow key or problematic cases to evaluate treatment-seeking behavior and changes in the explanatory model. They should work with survivor families to help determine their immediate the stigma attached, as well as future, notifying if compensation becomes available, and locating local NGOs that may assist with orphans' needs overall. In the final phases, they should develop and administer systematic questionnaires to community members, survivors to understand persistent symptoms, and healthcare workers to determine their understanding of disease, family problems related to the outbreak, and so on. They should assist impacted families in organizing and locating national and international assistance. They should also work to write a report for the Ministry of Health before leaving the field. And again, a lot of the work that anthropologists do and medical anthropologists do is collaborative in nature, and anthropologists would seek, again, to integrate everything that is known about a particular condition as they move forward in these various reports. But in the context of Ebola, rapid response is necessary, and indeed medical anthropologists are on the front lines often of determining very important factors that would limit the long-term spread of the disease. And again, if you're interested in this work, it's by Barry Hewlett and Bonnie Hewlett. It's a 2006 or 2008 book published by Thompson Wadsworth, and it's Ebola, Culture, and Politics, the Anthropology of Emerging Disease. So in these lectures here, I hope to have provided you a notion of what health is, who has the power to determine what health is, how global health issues should be addressed globally, who are the actors that become involved, the World Health Organizations. Certainly we see a lot of international response, but as anthropologists stress time and again, we must remember the importance of local individuals and local perceptions of health and wellness and how they interact with biomedical systems, as well as international agencies and government agencies that are coming into an area that there has been potentially a long-term distrust of these individuals, some of which, as Niehaus points out, for very good reason overall. I talked about some of the history of medical anthropology as a discipline. We looked at various infectious diseases following Jared Diamond's work from earlier in the semester. I touched on malaria, went into a little bit more depth on HIV and AIDS, and finally ended with a discussion on Ebola. There are, of course, extensive resources on BOLT, media resources on Ebola, as well as articles that I would encourage you to peruse at your leisure. Thank you.